Hola.
Here you are.
Thank you. Yo soy Wendy. Primera vez en Colombia. It's my sincere pleasure to be with you here today in your beautiful country. And as I say, my first visit to Colombia, and hopefully it's not my last. The speakers that you have heard preceding me, I think you will hear that we are reinforcing many of the same messages, and thus the linkages and the continuity between the presentations, I think, will be extremely meaningful. The focus of my talk is on quality, of course, but the issue of affordability and the issue of the cost of quality. And I'm sure your country is perhaps like my country and many others. However, when there's a budget problem, when there are financial problems, the CEOs, the leaders of the organization look to say, where can you cut? Where are we going to remove positions? Where can we make change? And I would say up until a decade ago, and I can say this in Canada, up until a decade ago, if there had to be cuts made, it would be in the area of the quality improvement coordinators. Perhaps you would remove some educators. Sort of on that qualitative side, that's where the sacrifice would be. Thankfully, that direction is changing and continues to change. But I'll be focusing on that issue of the relationship of how quality actually is essential if you want to have an efficient and sustainable organization. So I'll be reviewing with you the quality journey, and you've already heard quite a bit about that, and I will not repeat that. What is a sustainable, high-performing system? What's the evidence of a safe, affordable system? And there are foundational elements. And as Dr. Rulis just said, it's not a matter of saying, here's the standard, go and do it, because we know that can fail. There are other elements needed to ensure the environment is supportive and indeed it will be effective. So we will look at the fact that quality and sustainability are the two sides of the same coin, and evidence that sustainable organizations must focus on quality. Now, I'll be the first to say, I think I'm speaking to the converted here, so hopefully I'm not insulting anyone who's attending, because clearly we are here because we are committed to that. You will also note that there's a number of slides here, and they're really for your reference later on. So I will go quickly through a number of them. I don't intend to use all of them in any detail, but they are there for your future reference. We'll talk briefly about the quality journey, and I think as those speakers preceding me have spoken about what's happened, not in the last few decades, it's what's happened in the last century plus. The search for quality started in the early 1900s, if not before. You can even go back to Florence Nightingale and the issue of washing hands and infection rates and so on, and having standards. I think what is important, and I'll look at my third point on this slide, and I believe is that patient safety, in my view, has taken the lid off quality. So while we have all pursued quality for many, many years, it's been elusive. It's been sacrificial. It's been something we have not necessarily been able to get to the top, even though many of us have said quality care is really important. But thankfully, with the release of the IOM report in 1999, and deaths directly due to preventable medical errors, people started to listen. And in particular, the leaders from government through to the leaders of our healthcare organizations, we now had their attention. And so there are many, many initiatives, thanks to the patient safety movement, in my view, which have said quality is important. Quality really is a business strategy and something we must focus on. A point I want to share with you, and Sheila spoke to this as well, and Dr. Ross, is when you're looking at quality, there's many ways of defining it. And Accreditation Canada, the organization I most recently worked with, these are the dimensions of quality as defined by Accreditation Canada. You will note of those 8 dimensions, safety is one of them. Safety is one. Client-centeredness is one dimension. You'll note efficiency. So the whole issue, quality does mean it's being done in an efficient way, and we are being conscientious in how we are exercising our direction in quality. Population focus is identified there as a dimension. And just as two previous speakers have said, we've got to make sure we're thinking ahead to the population. It's one thing about this patient, this client, but what are we doing for the population? What is that national strategy? Move ahead to the Institute of Medicine. They have 6 attributes of a health system, a quality health system. You've got safety again. You've got patient-centered, timely. The word efficient is there again. So I think on our quality drive, there really is a commitment to that efficiency within ensuring we move forward if we truly want to have quality. Now, a point I want to make is that when we're looking at quality, we should not look at only one dimension. And I guess what worries me about the safety direction is if you focus too much on safety, you're going to lose the quality. Because safety is very, very focused, and we've tended to focus in specific areas, whether it's a surgical safety checklist or whether it's something to do with control of infection. No question, extremely important. But what about those other dimensions of quality? If we're not client-centered, we're going to make sure that client doesn't have an infection. However, do they have the education they require to look after themselves when they get home? Is there appropriate continuity to the community, and so on? All of those dimensions are important. So when we look at quality, we must balance all dimensions and not sacrifice one in the interest of another. And there's already been reference to Triple Aim out of the Institute for Healthcare Improvement in the States. And again, there is reference to the cost piece, to having the lower cost per case, and to looking at that, as well as patient experience and populations. So it's important that we do simultaneously improve and look at all of the dimensions. Now, I think the question is, though, what lens are you wearing when you define quality? We've all been a patient, and we've all worked with family members and friends who have been ill. Your definition of quality at that time might be a little different than what you would say it is now. As a professional, a physician will have a slightly different balance of that view than perhaps the nurse will have. The caregivers, your spouse, your children, grandparents as well have their own definition, and so on. Academics, government, and the population or community at large have another definition of quality. I would hope we all challenge ourselves in whatever definition or whatever perspective we're bringing, that we're saying we are going to do the best for the individual for whom we're caring or with whom we are caring, and that they need to be at the center. So this next table basically is showing, I hope the whole table comes up. There we are, is showing what some of the potential variations in perspectives on quality might be. And none of them are wrong, they're all right. And depending on your lens at any particular point in time, it's very important that we consider that that is going to vary. So why do we care about quality? Again, I know I'm speaking to the converted here. It does contribute to completing and achieving the best possible health outcomes, both population and individual. We need it to achieve efficiency because poor quality is expensive. We can't afford poor quality. It will improve organizational and system performance and sustainability. And I think the concern about many countries and regions is, given the escalating cost, given the escalating challenge of our populations, given the aging reality and the complexities of care that continue to escalate. How do we ensure we have a sustainable system for the future and that we don't burn out now when we need to be ready and prepared for what is ahead of us? It does demonstrate accountability. It does show others that we are committed to being accountable for what we are doing and the dollars that we have. And it does contribute to lessening and controlling risk. Now, what is a sustainable, affordable, high-performing system? And my thesis here is that you cannot have a sustainable, high-performing system without quality. And what are some of the characteristics? So bear with me as I will go through some literature in this regard, and I have identified the source of these individuals on the particular slide and would be happy to help you if you want more information. But there's some excellent research on high-performing systems, and I think this reinforces some of what you've already heard. This is research which was conducted by Ross Baker in Canada, who's done quite a bit of research in this area. And here are some of the characteristics which he and his colleagues were able to identify through research. High-performing system that patients have access to care, experience seamless care transitions, and can communicate effectively with care teams. Now, I think you and I know that's a challenge at the best of times, and it's one thing to be providing our care within a hospital or within a clinic, but how do you deal effectively with the transition and transitions of care and communicate effectively? That patients experience increasingly safe, effective, efficient, and high-quality care. The word there is increasingly. Organizations and systems continue to learn and measure performance, working towards a culture of quality and improvement. Providers have an easier time delivering care to their patients and coordinating care with others. I think the next point is probably one of the most important. The core strategy is a focus on quality and systems improvement. So if all of you looked at your strategic plans, if all of you within whatever lens you are wearing look strategically at where you are focused in your organization, is your core strategy a focus on quality and systems improvement? The next point important, and it just backs up very nicely on Dr. Lewellis' comment, the existence of national or systems level strategies around qualities have been described as a requirement for the achievement of the mission of high performance. And I did take that right out of Ross's article. Another important issue is the levels of leadership are aligned. There's many levels of leadership in an organization, from the manager in the emergency department through to the clinic, to a long-term care leader, to the CEO, right through to government, regional coordination, and leaders such as Teresa and others. But are those leaders aligned? Are the leaders aligned in what our quality direction is and what our quality goals are? Because we can all be very committed with very, very incredible, noteworthy goals, yet not be aligned and therefore less effective. And enhanced that there is a system governance in place. Just basically, poor quality is expensive. I don't need to elaborate on that particular point. We do know it lengthens hospitalization, increased lengths of stay. If someone's in hospital an extended period of time, they're also not getting back to work. You've got the economic impact of that for both the individual as well as their employer, the issue of disability, and the overall increased cost. Now, when we're thinking about the cost of quality, I think it's important when we're looking at this to think of cost savings, but also cost avoidance. Because often a strategy will be put in place and the manager or the CEO or someone will say, well, how much money can we pull out of that program then and transfer it to another program? There may not be obvious savings to pull out and transfer. It may be that it's cost avoidance. And thinking ahead to the future, that cost avoidance is critical to allow us to be able to deal with the other strains which are there. So both pieces of that equation are important, and it doesn't mean that one strategy is any less important. So the last point I have on that slide, just to emphasize also, is to think out of the box. We look at the savings, or we look at the effect of a particular strategy within the clinic, within the operating room, but when we look at the impact of that, think about what the impact is beyond. Think about what that impact is in the community. Think about what the impact is when the individual is now perhaps in rehabilitation or is in some other part of our healthcare system, and what is the true impact. And you may be shocked when that equation is put together that the impact is tenfold what it was when you actually were within the boundaries that you were initially looking at. Just some data, and the next few slides are about cost and quality data, so I'll move quickly through these. This was 2008 data in an article which was published on the relationship of hospital quality and cost per case in Hawaii I'll just look at the second bullet. Hospitals with the lowest cost per case tended to have the best quality of care. So just keep that in mind. Surgical safety checklist. This is one which has had some very, very good promising research over the last few years. I would hypothesize that a number of your operating rooms perhaps are using the surgical safety checklist, and there's been great research to show what the impacts are. And the complication rates that have decreased, you can see inpatient complications reduced by 11% to 7%. Surgical site, I've got a typo there, from 20.5 to 3.6% and so on. And those translate into immense benefits to speed of recovery, to the cost to the organization, to the individual back to work sooner, home to their family, and so on. However, it's not all about implementing a process or a procedure, just as I said. So there was a study conducted by Anne Matlow, a colleague of mine in Canada, who looked at this, and surgical checklist not a guarantee. So this is a team which completed the surgical checklist, and they conducted wrong site surgery. And the conclusion of this review that was done, and I'd refer you to that, was that a committed culture must be in place to support safety initiatives. So there really is a need for a culture that supports, believes in, and will enable to sustain what we're talking about. So it's not just here's a regulation, it's not just here's a checklist or here's a standard. Is the culture there to enable and support these things happening? What we find in the accreditation organization that I've been with is that many organizations are completing their surgical checklist, but we also find ORs where the checklist was completed before everyone was in the room. You know, to check. And really is their commitment to what the value of it is and how to use it. Estimated cost of complications. Just briefly, this was a study in looking at data of both California and Maryland, and they looked at the incremental cost of hospital-acquired complications and an increase in what the cost was. And the increase in cost in California was 9.39%, and in Maryland, 9.63%. In Canada, we did an analysis of readmissions. And I'll just refer you to the second point here, in that readmissions to acute care cost an estimated $1.8 billion, Canadian dollars, excluding physician fees. And this is looking at Canada alone. And the statement that while not all readmissions are avoidable, research suggests 9 to 59% of readmissions could be prevented. So now this then would be cost avoidance, right? As opposed to savings, it would be cost avoidance. But absolutely critical data. The cost of acquiring an infection, estimated in Canadian dollars, 2,265 to 22,000 nosocomial bloodstream infections. The cost anywhere from $3,200 to $29,000. There's also a study I don't have here on the cost of decubitus ulcer in patients, and the cost in Canadian dollars can be estimated as high as $30,000 in treatment, length of stay, etc. Now I'm going to skip a few slides here in order to, in the interest of time. This is a study out of the paper out of the Health Foundation in the UK, and some of you may find some of their sources of great value to you. They recently reviewed in November of 2015 3 projects and looked at whether or not they succeeded in both raising quality and in cost savings. And they found that indeed that was the result they found. The point to make here that was also a finding was that innovation was inspired by the leaders who felt passionate about improving care and were determined to prove the effectiveness of the solution. So again, we're looking at leadership and we're looking at culture. Now, I think important to not be totally Pollyanna in this. I think we recognize that while I'm presenting a bit of a a bias to quality and cost. Also important that sometimes there are things that, can we really prove this has had a positive value on our effective use? Can we improve? Can we reduce waste and increase productivity? An important point too, that savings depend on effective implementation of the improvement. You can't just lift what someone else has done and say, we're going to try that and put it in place. And I think, again, that point's been made by several of my colleagues, that we need to learn from each other. Here's an experience that's been gained in another country. Let's understand how it's been done. But then we need to look carefully at, okay, let's understand our own environment. How does it fit with our context? And now, how do we move forward? So very important that we need to look carefully at how we're going to implement it in order to do it very, very well. Just a recent update from the US, and it builds a bit on what Dr. Relas was saying as well, is that in the US, they're saying that between 2010 and 13, they believe 50,000 fewer patients have died in hospital due to a lowering of hospital-acquired complications, and believe that the savings actually there are $12 billion in healthcare. That was a recent statistic. And then 30 to 50% of the US costs, however, they believe are due to non-beneficial care. So I think there's a whole area now as we move ahead and start looking at the care we are providing. Is the care needed? Is it appropriate? Did that individual need the MRI to start with? Was there another way? Was surgery indicated? So let's look in the mirror and make sure we're as critical as we can be about ourselves and what's been done. So the limitations thus far, though, we have to be realistic about the limitations on the research. One weakness or reality is that the research has been on acute care. I think you and I know that probably 85% of care is provided in the community. It's provided in the home by the family physician and in other areas. And we have a great wealth of area of research to be done, and it is starting, and hopefully I expect some of you are involved in that, to really look at the quality of care being provided there, and how can we improve that, and how do we look at its effectiveness. So we've got to really reach out, and we need to begin doing that aggressively beyond acute care. Focus has been on economic burden of adverse events and nosocomial infections. And again, we're talking about a major hospital focus. So there's a significant gap in what we need to look at. And again, the focus of care has been within the silo of healthcare, as opposed to the focus of the cost of care, recognizing how care spreads its tentacles. And what does that mean when an individual gets back to work in 2 weeks instead of 2 months, and what really are the benefits there and how you extend that, and look across the continuum of care and not look only within the silos. Adjusting frail status has been an issue and variable, and variabilities in analysis is there. And I think there is a quote from the particular article here of Dr. Hussey that the association between healthcare cost and quality is still poorly understood. So although I'm giving you a fairly emphatic comment about the relationship between the two, we recognize there's a lot of work there. And it's not simple. So let me, as I come to conclusion here, it's not simple. It's not just a matter of identifying what others have done and let's moving forward. We do need to learn from others' successes and failures, and don't reinvent the wheel. I see repeatedly in Canada, now Canada, as some of you know, we're really 14 healthcare systems. We're a federation. And so we have 10 provinces, we have 3 territories, and then we have some national programs. So Aboriginal Health in Canada is a national program. The program for the Canadian Forces is national, and so on. However, healthcare is within each province and territory. So firsthand, I can tell you about a bit of a fractionated system where we're not learning from each other across our own country, and we all need to do better in that way. And a point I've already made, a successful initiative elsewhere may not be implemented as it is in your organization. It must be suited to the context. So somewhere else they've done it, we're putting it in here. 6 months later, you say, why is this not working? Well, no surprise. You've got to really look carefully at how it fits in the context. And then there are foundational elements. So what are some of those foundational elements that are needed in order to help us bring some of these initiatives forward? And I'll go through these in a fairly prompt way. The main elements are strong and effective leadership, a long-term, I'll expand in a moment, but a long-term vision. Make sure you focus on the continuum. The challenges in healthcare are at the transitions. So we just focus in the hospital or just in long-term care or just in rehab or just in clinic. It's the transition we've got to keep in mind. There's got to be that focus on culture and a belief in the importance of that and an effective monitoring system. So a few points about leadership. I've already spoken to the importance of this, and I'm going to be speaking to it a bit more on Friday. But leadership must have a vision and a clear strategic plan. And a clear plan that when you're talking about the strategy of where this hospital or system or country is going to be in a few years, where do we want to be in 10 years, and what will that look like? Leadership with knowledge and understanding about quality of care. I've been to organizations where the CEO will say, quality, that's John's responsibility. John's the vice president for quality. He's looking after quality. You know, I'm the CEO and I'm doing this. If the CEO and the board and the governance don't lead quality, who is? So it's absolutely critical to have the leadership, and then I move that leadership through the whole organization. And it is the first item on the agenda of a meeting. Leadership that walks the talk. So if you believe in quality, are you talking about quality? Are you asking about quality? And that cultivates a safety culture. And it's those safety cultures, as you and I know, of no blame, transparency, risk-taking, and it's supportive. And it's not the leader who, when something goes wrong, who says, who did that? Now, you and I know, many of us are mothers, fed children, you know, and when the lamp falls over, do you say, oh dear, that lamp fell over and it's broken? Or do you say, who knocked the lamp over? So I think we all, maybe at sometimes, there can be a bit of a blame feature in where we may look for. Why did that happen? Who did this? Stand back, take that system approach, and how do we really have a culture that's a safety culture? On the safety culture, again, to carry on, that there are shared beliefs and values. Recruit and train with safety and quality in mind. So when you hire people, when you recruit, are there questions in there which seek the values of those you're going to bring in? Are you bringing in those with values that are supportive of where you want to take the organization? Is it a learning environment that when something doesn't go the way you would hope it would go, that constructively you sit down after, what have we learned from this? And you want to debrief when things didn't go wrong, but don't forget to debrief when things have gone right. You know, like if something that's really successful, debrief. Wow, let's pat ourselves on the back, but don't stop there. Analyze why this went right. You'll be surprised what you will learn from what went right. Open communication and partnership with the patient and client, their engagement. And that means they're an equal partner at the table. Not that you pull them in at the last minute to ask if this is okay, but are they an equal partner at the table? And of course, a just culture. This is one of my favorite phrases, that culture eats strategy for lunch. So you can have the strategy, get that surgical safety checklist in place, and we'll all be fine. But if you don't have the culture that's enabling that to happen and that you continually reinforce it, you've just eaten it up. There was a study in Canada. We looked at some of our data and found that organizations that have boards, governance structures that believe strongly in safety, their organizations performed higher on patient safety measures. The other thing that's important, and a pet of mine, is a focus on the quality of work life. If you're going to look after, have a culture of caring that looks after your clients, you've got to care for your staff. You have to care for the staff if you want them to care for the client or patient. And the leader that really demonstrates that caring, and that means caring for the physicians, caring for your volunteers, caring for those who are providing the care and so on, is extremely important. And a strong supportive focus on all staff is critical. It's critical that there is a quality plan, a quality improvement plan. It's not a matter of 8 or 10 different initiatives, that there is a coordinated plan for the organization, and a coordinated plan then that cascades through. And I'll tell you my bias, and that is that accreditation should be part of that plan. Accreditation to me is not separate from a quality improvement plan. The accreditation process and how that weaves into what's going to happen is part of the country's quality improvement plan, part of your organization's quality improvement plan, and there are standards and things you can use there to help you with quality improvement. And recognize, I'll re-emphasize that quality, you need a balanced focus amongst all of those quality dimensions. We all know we cannot manage what we can't measure, and the importance of performance measures being regularly reviewed, and get these right through to the staff at the front line. The emergency team should know those key measures and what they're showing and how together you can move those and improve those, just as it's important for management and the government. Reinforce the importance of focusing on the continuum and make sure you're not measuring within a narrow silo. Very briefly, many of you, I'm sure, were aware of the crisis, the real problem in the UK in the mid-Staffordshire inquiry when there was an organization which had many deaths and complications that they tried to bring to the attention of government and others in the board, and they were ignored for too long. And then there was a significant inquiry, and many, many lessons from that inquiry that are still relevant. But if you, one that I will point out in particular here is a strong patient-centered healthcare leadership of the organization was missing and was required, and that was a factor in the issue. The involvement of patients, public, and staff in what is going on, and so on. So in summary, those foundational elements to allow us to move forward on that quality arena: leadership, long-term vision, setting that culture and maintaining it, the quality of work life, keeping a focus there, having a quality plan, the continuum, focus on the continuum, and of course the importance of measurement. And I will stop there. Thank you very much.